Good evening, everybody. Respected President Dr. Avinash Bhosle sir, Vice President Dr. Vikas Karne, then President-elect Dr. Rajesh Takadpalli, Treasurer Dr. Sachin Tandolkar, then the news editor, that is SAMS newsletter editor Dr. Shilpa Tivaskar, then on the today's esteemed invited chairperson Dr. Indrani Hemant Kumar Madam, our National ISAGC, then Dr. Kiran Kurtikoti sir, he is the president of Association of Obstetric and Gynae Maharashtra State Chapter. Then today's esteemed faculty, Dr. Kajal Jain, Professor Anesthesiology, that is in PGI Chandigarh, and Dr. Manisha Shembekar, a consultant anesthesiologist and director Omega Hospital, Nagpur. All past president, all past office bearers of the SAMS, then all GC members, all national GCs, all advisory SAMS, then all president and secretaries of the different various branches of Maharashtra state, then my dear ISCNs and all other dignitaries from other specialty. So I welcome you on behalf of SAMS and also hello Society of Anesthesiologists Kolhapur. I welcome you all in today's SAMS curriculum, that is towards safe motherhood. Before the proceedings, हे समोर का नाही सरकत आहे. हॅलो सर, हे समोर नाही दिसत आहे ना. मी परत शेअर करते. With the brief gift, today our Honorable Deputy CM of the Government of Maharashtra, late Shri Ajit Ashatai Anantrao Pawar, has passed away. So SAMS is paying the tribute to the that CM, our Honorable CM, Deputy CM, in respect of his so that his departed soul will be rest in peace. So I request all of you to mute yourself and observe 1 minute silence to pay tribute to the departed soul. Om Shanti Shanti Shanti. So with the blessings of Ma Saraswati and the rays of divine light, so we should proceed to the today's webinar. Now I request our President Avinash Bhosle sir to deliver his presidential address. Sir, mute आहात तुम्ही.
Hello, can you hear me? Hello.
Yes, we can hear you.
Yes. Good evening, all. Before starting today's webinar, we pay tribute to our Deputy CM, late Sri Ajit Pawar. We will continue with today's webinar, tinged with sadness. Our prayers and emotions are with the family members and well-wishers of our family. Now, I welcome you all for today's webinar, Science Curriculum, Safe Motherhood. Based on the data from India and international studies, females generally have a higher incidence of undergoing surgical procedure compared to males, often driven by obstetric and gynecology, and in some cases, higher rates of outpatient surgery. Overall incidence of is in India suggests a range of 1,729 surgeries per 1 lakh men and 1,916 surgeries per 1 lakh women per year. Cesarean section, that is C-section, is one of the most common, if not the most common major surgical procedure performed worldwide. The global rate of C-section has risen from roughly 7% in 1999 to over 21% currently. And in India, the C-section rate in private hospital have reached up to 49%, meaning nearly 1 in 2 deliveries in the private sector is a C-section. The challenges of the obstetric care are enormous, but with proper guidelines, we can ensure safety. This includes urgent management of maternal hypotension, prioritizing neuroaxial technique, effective use of adjuvant, and tailored care of high-risk conditions like preeclampsia or obstetric hemorrhage. The fact that death and complication in these young fit women are largely avoidable, which may be tragedy for their families and existing children. Anesthesiologists play a crucial role in safe motherhood, and learning from our renowned speakers and chairpersons will help us to enhance our skills and knowledge in this area. So let us make a difference by attending this webinar. I thanks all the speakers and chairperson for joining this webinar, and thank you very much. Over to Sheetal.
Thank you, sir. हे माझं समोरच नाही जात.
Yes, next.
Full screen केलेस का?
Hello. Today we have Dr. Shirish Pawar from senior anesthesiologist from the Kolhapur, has been appointed as the MMC observer. He is a MBBS DA. Then he is a senior consultant at Synapse Anesthesia and Critical Care Services. He is a president of ISA Kolhapur City branch in 2004 and 5, and president of Kolhapur Medical Association in 2010 to 11. So he has vast experience of doing anesthesia since 20 years. Welcome, sir. Now I request Dr. Avinash Bhosle, sir, to introduce our first chairperson, Dr. Indrayani Hemant Kumar, madam.
Yes, it's my pleasure to introduce Dr. Indrayani Hemant Kumar, ma'am. She is MBBS and MD anesthesia. She is professor and HOD anesthesia, pain and critical care, Symbiosis Women and SURHC Pune. Her major achievement: first rank MD and DA examination, current National Governing Council member, past president of RSFCP National, then president Maharashtra State Chapter of Indian Association of Pediatric Anesthesiologists. She is current Governing Council member of Indian College of Anesthesiologists. She is past Governing Council member of Society of Onco-Anesthesia, past Governing Council member of Association of Medical Consultants, Mumbai, past Governing Council member of Maharashtra State Chapter of ISA, and past President ISA Mumbai. She is member Specialist Board NBE, Fellowship awarded by Indian College of Anesthesiologists, FIC and SOA PCC. Then Harvard Bean Fellowship, he received a fellowship to train in cardiac anesthesiology. Then awards. She is awarded for Natya Kalaimani Award, Bharat Jyoti Award, and President Appreciation Award, ISA National. She had more than 20 chapters in books. Welcome, ma'am.
Now I request our President-elect, Dr. Rajesh Tagadpalli, sir, to introduce Dr. Kiran Kurtukoti, our next chairperson.
Good evening, all. This is my pleasure to introduce Dr. Kurtukoti, sir. He is a basically gynecologist, and as usual, when we are talking about the safe motherhood, there should be the combination of anesthesiologist and gynecologist to talk about. Presently, he is the president of AMOG for the year 2024 and 26. He is the founder president of Maharashtra College of Obstetrician and Gynecology. He is the founder president of AMOG Teachers Association. He is the director of Shashwat Multi-Speciality Hospital India Private Limited and Sanjeevan Hospital Pune. He is the director of Shashwat Hospital Aun. His major achievements in SOXY and AMOG, he is a chairperson of MT committee. He was in 2009 and he is a chairperson of MT committee AMOG in 2012. He is a chairperson of medical education, research and training AMOG in 2018 and he was a joint secretary AMOG 2009. He is a POX committee member since 25 years and he was organizing chairman, secretary of over 100 workshops, seminars and national conferences. He is a recipient of Dr. Siuli Rudra Sinha Prize for the best paper in endoscopy, AICOG Bangalore, and the recipient of CS Dawn Prize for the best paper at AICOG Chennai. He has various publication and research projects. He is the editor of Medical Abortion, SOXY Focus, author of Medical Abortion Drug Regime, RPL and SOXY Focus. He is the editor of AMOG Suraksha book in COVID and over 150 talks at a national and international conference. Thank you, sir. Over to Shital ma'am.
So it's my honor to introduce today's faculty, Dr. Kajal Jain. She is MBBS and MD Anesthesia. She is at present Professor and Head of the Department of Anesthesia, that is Postgraduate Institute of Medical Education and Research. It's Chandigarh. Then she is in charge of Trauma Intensive Care and it has Level 1 Advanced Trauma Care Center. She has mentored research in obstetric anesthesia, anesthesia in national and international forum. She is chairperson for the 3 years course in trauma anesthesia and acute care. She is a founder, honorary secretary of Society of Trauma Anesthesia, Critical Care in India. She is a recipient of COPS Award in 2002 and she is a recipient of ISA President Appreciation Award in 2021. She has various publications at Index Journal too. So welcome, ma'am. Now our next faculty is Dr. Manisha Shembekar. I request Dr. Shilpa Tivaskar ma'am to introduce Dr. Manisha Shembekar.
Yeah, it gives a great honor to introduce the dynamic personality of Dr. Manisha Shembekar Madam. Madam is MBBS MD anesthesiologist. She is a chief consultant anesthesiologist and managing director of Omega Hospital. Madam is executive member of AOA India and past president of ISA NCB. Madam is a recipient of Shrimati Sushila Sathe Award. Madam has to her credits President Appreciation Award 3 times. That's a great achievement, madam. And faculty at various international, national and state conferences. Madam has various publications to her credit in various index journals. We welcome you, madam. It's a great honor to listen to you. Thank you.
Thank you, Shilpa.
Now I request Dr. Kajal Jain ma'am to proceed for her delete.
Yeah, is my screen visible?
Yes.
Yes, ma'am.
Yes, ma'am. Yes.
Okay. So first and foremost, I really want to thank Society of Association of Maharashtra State. And I also want to tell you one thing that I also graduated and post-graduated from Maharashtra. So I am feeling like I am among my own folks because I was a student of Mahatma Gandhi Institute of Medical Sciences, Sevagram, in the year 1986. So it gives me immense pleasure to be addressing an audience who's very close to my heart. And even more so because the topic is also very close to my heart. And then I see my chairpersons are also very close to my heart. So it's a very great evening for me today. And then talking on this topic today of national importance, obstetric hemorrhage. Obstetric hemorrhage, we all understand very well, is a obstetric emergency most of the times. And we have to collaborate with our colleagues, obstetric colleagues, in managing these cases. It's a big collaborative effort on part of the two teams, and there are so many other stakeholders also involved in managing these women who are actively bleeding and can lose their life in a span of a few minutes. So if we talk about it together and look at the recent advances, there is a chance that we will be able to bring down the maternal mortality in a significant fashion. And that is what the motto is all over the globe, that we should end PPH now. So going ahead with the slides, I would just like to say that, as I've already alluded to, that it should be in a collaborative quality improvement approaches with both the teams, and it should start way ahead. That is, it should start with the aspects of care for obstetric patients, so that we are able to develop protocols which are like precision based from bedside to the operating room care. And maybe we should create some algorithms which are conducive to our own settings, because all of us do not come from the same resources. Although our country is supposed to be low resource or middle income country, but there are certain places which are having high resources vis-a-vis other areas which are not having good resources. So we have to now be very mindful of what is available to us, because that is the latest recommendation by Federation of Obstetrics and Gynae meetings, that try to create algorithms which are the best for you, and don't look for the best in the literature, because that's not always okay for the people who are managing these patients at their own settings. And that may be one of the reasons why we are losing mothers, because of the want of the best. So this is a big major change which has taken place, among others, which I'll be talking about in the subsequent slides, that you should look forward to creation of those algorithms which are important for you in your own settings. So the slide is okay. So let's first talk about the risk scoring. So about risk scoring, there are three major bodies, all belonging to obstetrics community. The Association of Midwifery and Women's Health, and then there is a Collaborative Maternal Quality Control by California, and then there's an American College of Obstetric and Gynae, which are promoting the PPH bundle, which is the 6 R's: readiness, recognition and prevention, response, reporting system learning, and then equitable and supportive care for all. So they're highlighting this uh, very in with a lot of stress. And among the risk scoring parameters, let us understand what is a low risk patient, what is a medium risk, and a high risk. But that said, be sure that any women can bleed. That is why we have had deaths among the poorest of the poor and the richest of rich. So these are just a markers to tell you that this patient is a low risk, less likelihood to bleed, but that doesn't mean that she will not bleed. So the high risk one, I would like to read out. Otherwise, the other ones, you can read them up yourself. So placenta previa or low-lying placenta, then placenta accreta spectrum, anemia, and then low platelet count, active bleeding greater than bloody show, and known coagulopathies are red flagged. So it's very, very important that we also partner with our obstetric colleagues early on for women who are at risk in the outpatient clinic. And this should be based on the three goals. Like, do I need further testing or consultations? And as an example, I can say, like, if the patient is having low platelet counts or gestational thrombocytopenia, maybe you would like to understand if this patient is also having another high risk factor, and then you can plan ahead. And then you should also counsel the patient about her specific risks and options for anesthetic management during your this visit, and then draw out a plan with your colleagues, which doesn't include only obstetrician. If your patient is at risk, you may need help of a transfusion medicine, or your surgical colleagues like urologists or or your vascular surgeon. So you have to make a plan much ahead if the woman is deemed at risk for PPH. So right now, the recommendations by FIGO and International Confederation of Midwives, along with WHO, have laid a lot of stress on anemia. So now they are talking about, like, let's not talk about 10 grams as anemia. Let's target 11 grams. And why so? Because it gives us a window of, opportunity to manage these women who have a slightly higher hemoglobin vis-a-vis the ones who are having 10 grams. So these are not, these are equations which can just help you bail out a situation much earlier. So more stress is being laid on early recognition. So if you just bring down your values from 11 to 10, maybe you will raise your guards early and start acting early, which is what FIGO and WHO is recommending now. So the causes and approximate incidences, they don't change. They have been age old the same, like the 4 T's: atonic uterus, lacerations, hematoma, inversions, ruptures as a part of trauma. And then as a part of tissue, it's retained tissue, invasive placenta, and then thrombin, like inherited hemorrhagic disorder. And we also know what are the drugs to be used. So we know that oxytocin is good, but for those places where there is no availability of storing it in a, in a cold storage chain, people are now talking about using carbitocin, because carbitocin has been shown to be quite beneficial in places where the access to cold chain maintenance is not possible. And in these FIGO guidelines, they've even said that if you do not have oxytocin, do not just chase the guidelines, because guidelines are recommending oxytocin or carbitocin, but you do not have either. If you have methergin, then please go ahead and use that. But that is not the ideal drug to use. But that doesn't mean that you can't use it. So these are the second line of choices, which should be used in case you're not available with the best choice possible. So talking about the definition of PPH, are you aware what is the definition of PPH? So there are variable definitions of PPH, with the ones which are very commonly cited are by American College of Obstetrics and Gynae, that is a little blood loss or signs of hypovolemia within 24 hours of birth, regardless of the delivery mode. To do away with our late diagnosis, they had clubbed it into this. And WHO says more than 500 mils for vaginal birth or 1 liter for cesarean, acknowledging the resource limitations and estimation challenges. And I'm going to tell you what happens when a woman loses more than 500 mils of blood volume. So sometimes she just becomes inappropriately fearful. She becomes restless, and we misdiagnose her fear and restlessness as her being, whimsical. So sometimes it is just the first sign to be seen. And then a tachycardia, which confuses you with her physiological parameters, in which you are making up your mind whether this 100 beats per minute is due to hypovolemia, inadequate pain control, or is the routine maternal tachycardia. And then you look at the blood pressure values. And for a woman who is just about 19 or 20 or 22 years, maybe the values of 85 by 45 do not ring a bell to you because she looks apparently okay. And now we are talking more and more about shock index. So shock index is nothing but just a ratio of heart rate divided by blood pressure. And shock index of more than 0.9 should warrant your escalation of care. More than 1 means she has lost a significant volume, and more than 1.2, you should understand, like, what is the ABG value in this case. If it is going beyond, base excess is going beyond -6, and the pH values are dropping. So you can understand there's a hypoperfusion which is happening, there's a hypovolemia, and this needs to be taken care of immediately. So the lactate levels also indicate a perfusion deficit, and that needs to be corrected with immediate sense of time. Time is of lot of essence in these women. As we know, if she's bleeding profusely, then uterus receives the blood supply at the rate of 700 mils per minute, and a woman can lose her entire blood volume in 8 minutes. So you also keep a check on oliguria, and if the urine output is less than 500 mils, uh, that also signifies, that the patient is compensating, and we need to look at her blood loss estimation. Coagulopathy, we will be talking about it, how to detect it and how to treat it. So another thing which I found it very interesting and I want to bring to the audience today is that we've been talking about this 500 mils of blood loss, and that is because traditionally we are being taught that mothers should be treated for deadly postpartum hemorrhage after losing 500 mils of blood loss. But lately, the in this Lancet volume of October 2025, they have concluded a meta-analysis, a global study, and look at the volume of patients involved in this study. There are more than 3 lakh mothers across 23 countries, and they have found the flaw with this 500 mils definition, because they found that this rule was simply not sensitive enough, and not sensitive enough for many mothers, especially in low resources. And that touches our heart, because probably it is meant for countries like ours, that this weight is indeed fatal, 500 mils of blood loss. So what are they saying now? They're saying the biggest story of maternal health you haven't heard. They're asking you to start your vigilance at 300 mils of blood loss. The new rule says act at 300 mils plus any abnormal vital signs, because they want you to escalate your care. The more time you wait, okay, 500 loss, then I will start acting, then the woman doesn't give you time. So now they are asking you to start acting at 300 mils plus any abnormal vital sign, because we are targeting at ending PPH. It's all about us, that why we are failing to recognize these women early. Why are we waiting for the for 500 for some numerical values to come? Also, the more stress is being laid on creating forms like a postpartum fluid form. They're asking you to start monitoring your patients, not within that 24 hours of span called, which is called as primary PPH and then secondary PPH. Now the organizations are focusing on making a postpartum fluid control form. They're asking you to observe the woman closely in the first 2 hours and look at the volumes administered, urine output, and look at the bleeding. For bleeding, quantify bleeding. Don't do eyeballing. Eyeballing is just not acceptable, because it always underestimates the blood loss. More so if the woman is young and you are not mindful of her uh, obstetric status. So this is one randomized trial of early detection and treatment of postpartum hemorrhage, which included 80 secondary level hospitals across Kenya, Nigeria, South Africa, Tanzania. Again, a large number of patients who underwent vaginal delivery were given these early detection and trigger criteria. This is called an emotive trial. And then massage of uterus, oxytocin drugs. These are the protocols which they followed. And looking at these protocols, they found there was a 60% reduction in the mortality of mothers. So it's a very big landmark trial, emotive trial. Start early and do not inaccurately assess the blood loss. As I've already said, visual estimation is just unreliable. It underestimates. Delayed misdiagnosis, hemorrhagic shock, mortality, late management, late tranexamic acid. The minute if you diagnose your women at after 3 hours of her blood loss and then you start tranexamic acid, the efficacy is lost. We know it. It is only 10% vis-a-vis 90% if you had given it within 3 hours. So objective quantification saves life. Let us learn this today, that we need to objectively quantify blood losses. We should go ahead and get these brass V drapes. Brass V drapes are under buttock drapes, which are calibrated. And when the woman is delivering, you can easily look on how much blood loss she has undergone. Also, you can be, your hospital specific. These are some specifics which have been drawn from various centers. and they show how much each ml of each square absorbs. Or there is a bucket which is calibrated, and there is a maternal well tray which is also, you can see there are two kidney tray like things which are pre-quantified. If it fills, like this would be the blood loss. And then you should also know the weights and dry weights and the wet weights of your mops to understand how much is the blood loss. If you do not have a brass bead drape, this is a very simple method somebody has given and which I've clipped and put it in the slide, that it's a very easy way to make a brass bead drape, and you can calibrate rather than saying that it would be cost effective for my setting. So what are the clinical tools for PPH detection? As I've already talked about shock index, let's talk about what are the vital signs. So what are the other surrogate indicators when you cannot quantify? Some people are looking at hematocrit drops, some people are looking at hemodynamic instability, but I feel they're very late signs. We have to start looking at 300 mils plus abnormal hemodynamic sign, pulse more than 100, shock index more than 1, systolic pressures less than 100, and objectively measured losses of more than 500 mils, which occur within 24 hours. These are, and as I've already said, this is the new thing, vigilance during the first 2 hours. Make the chart and develop more things in your own unit. So if your patients have lost more than a liter and you more than rather I would say more than 2.5 liters. This is written a little wrongly. So you have to activate the PPH protocol. And here in PPH protocol, we are talking about not only 1:1:1 transfusion. We are also talking about the 70s. So this slide is my hot favorite, and I tell all my residents to rehearse this slide. We have even pasted these laminates in our theaters, which talks about 7 steps which you have to do when your patient is actively bleeding. Like, you trigger the protocol in the sense you send a call to your transfusion medicine people and you tell that the woman is actively bleeding and I need help. So team prep and performance, you need more hands. So you have to see how many more hands can you get, because you need to then tell them who does what. Early tranexamic acid. The other thing which is very, very important is, since this patient is actively bleeding, her tests should be sent hourly. What tests? Coagulation tests. Very, very important. Because if you do not send the tests, then you will not be able to manage her coagulopathy, which is now coming as a separate entity, obstetric coagulopathy, and you will not be able to make a clot. So the whole thing is to make a clot along with the source control. Source control is happening by our obstetric colleagues. Our job is to make a clot. So you transfusion to target, which is typically 7 grams, and there is a lot of stress on temperature management. And once everything is done, you even have to terminate the protocol by sending the call back to your colleagues that the woman has stopped bleeding now. So, as I've said, the first step is to ask for help and start this. And please make a chart like this, which designates the team leader, one person who reads out the checklists, and then you announce the cumulative blood loss from time to time, and then you make a record of the vital signs. Also determine the stage of hemorrhagic shock. So we should know that if a patient has lost more than 40% of her blood volume, what is going to be her vital signs and her blood gas analysis. So we also lay a lot of stress as anesthesiologist. I do not have to, remind you of the wide bore IV access to large bore cannulas and maintenance of temperature. So ensure that you have a warming device. So for some normal deliveries, we have advocated in low resource places the use of normal saline bottles, which are wrapped up properly in a blanket or a towel so that she doesn't have burns. They can be placed if you do not have any warming device. So that is what I'm saying. The new guidelines are stressing on management as is available to you as the best possible. So preoperative and antibiotic prophylaxis 1 hour prior to surgery, repeated if the surgery is prolonged or more than 3 hours or severe bleeding occurs. So do remember to do this antibiotic also. And we are talking about hemostatic reanimation, like Everything goes hand in hand. It is not that first you give red blood cells and then you give, because you know that obstetric patients, they are requiring more of coagulation factors than the other population or the other settings. So early and aggressive blood product replacement is the way forward. Goal directed hemostatic resuscitation. I will highlight the role of calcium here because there are two things which are happening. One is woman is losing blood, and through that blood, she's also losing all her cations, and she's also receiving blood. So both things are happening. So if she's receiving large volume of red blood cells, then that contains citrate, because citrate doesn't allow the blood to clot. But once the citrate gets into the body, it takes out all the calcium also. So mother turns hypocalcemic. And let me tell you, my friends, that calcium figures in at so many steps of coagulation cascade. Just go back to your extrinsic and intrinsic pathway, and you will realize that calcium is sitting at numerous steps. So if calcium is not available, then she is not likely to clot, and our whole purpose is to stop the bleed. So there are many factors which lead to loss of calcium, and the lethal triad, which is happening because the woman is, actively bleeding, is compounded by this loss of calcium also. So there's a recommendation to give 1 gram calcium chloride if you have given 4 units of packed cells, or 3 grams of calcium gluconate, whatever is available to you. But be mindful of the loss of calcium as also one of the factors leading to, you know, um, death of the patient, as the patient doesn't clot well. So talking about tranexamic acid, we are all very aware of the women's trial, which has given us this landmark decision that administration of tranexamic acid is beneficial in women who is actively bleeding. Here, I just want to add a point that there is no role of prophylactic tranexamic acid, but there is definitely a benefit of giving if the woman is bleeding. In those situations, it acts on the plasminogen plasmin pathway, and it blocks the conversion of the same, and leading to uh, 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 blockage of the fibrin degradation product. So it is an anti-fibrinolytic, much of use to us all in a woman who's actively bleeding. So this has already been seen, and I have already informed to you. So it should be given. The doses are 1 gram in 10 mils at 1 ml per minute, and the second dose 1 gram if the bleeding continues. I will laid stress on serial investigations, and this is one thing which I follow very diligently in my clinical practice. My residents have to give me the latest values of point of care testing. We have available to us sonoclot, but do not worry if you do not have access to viscoelastic testing. Those of you who have a lab available to you can go ahead with your platelet count, prothrombin time. Just be aware of the turnaround time in your setting. For those who are working in very remote areas who do not have any access to these two things, can even simply use the old technique of that glass tube, which is stuck to the wall of your OT, and you can see the clotting time and the clot retraction time. That's also good enough to go. So these are certain things which you should be mindful of, like when you're managing massive hemorrhage, like the temperature, calcium. You can think about cell salvage, but we do not have much evidence if favoring, although we have started using it. You have to be mindful of the immunization and the cell wash for amniotic fluids. And then point of care diagnostics. And then the most important slide is targeting. So you should target a hemoglobin of 7, platelets more than 75. Usually you do not need to give too many platelet transfusion, because you almost keep up your levels of 75 to 100. What is more important is keeping fibrinogen levels more than 2, because in pregnancy we have slightly higher fibrinogen level, as pregnancy is a prothrombotic state. So we need to have more fibrinogen levels, and that is why there is a role to give cryoprecipitates, and I will be talking about in the next slide. So after talking about all these things, let me see how wise you have become. So quickly, I'll go through this case because I've spent some time and I have got, I think, 5 more minutes. So I'll take you to a case. Just picture this. There is an OB-GYN on the floor and delivery reaches out to you for guidance about a patient with obstetric hemorrhage. Patient is in the interventional radiology suite for uterine artery embolization. The history says patient is a 36 years old, body mass index 41, slightly obese, gravida 4, para 3, who had a vaginal birth of twins 2 hours ago. Her obstetric history includes a cesarean delivery for breech, followed by 2 vaginal deliveries, so she's a high risk case. So her third delivery had a mild PPH, about 1,100 mils, attributable to uteronectomy. During that delivery, she received additional uterotonics, 1 gram of tranexamic acid, but did not require any surgical intervention or transfusion. This pregnancy was complicated by preeclampsia, requiring admission to the hospital at 35 weeks of gestation. When she was admitted, her blood pressures showed 162 by 90, and she had raised alanine aminotransferases and LDH. Hemoglobin was 11, platelet count was 1,38,000. She was started on Lebit and Maxel. She was a case of preeclampsia, right? So as both fetuses were cephalic presenting, an induction was initiated. She was delivered 32 hours later. With delivery of the second infant, she received carbetocin to prevent uterine atony, but 4 minutes after delivery, vaginal bleeding was brisk and uterine tone was unsatisfactory. The quantitative blood loss was approximately 2 liters with ongoing bleeding, so embolization of arteries was believed to be indicated. So the massive obstetric hemorrhage protocol was activated and patient was transferred to radiology suite with the 4 units of uncross matched O negative blood transfused in this case. So while attempting uterine artery embolization, the patient's hemodynamics deteriorate. Bakri balloon blood reservoir measured an additional 900 mils. Her hemoglobin dropped down to 8, platelet counts dropped down further. Fibrinogen levels were grossly deranged and INR was 1.5. Now the team concludes that a hysterectomy is required immediately because of inability to control bleeding with embolization and hemodynamic instability. So request to consulting hematologist to provide guidance regarding optimal hemostatic response given the recent lab testing results. So what's going on here is that we need to understand that PT and APTT in pregnant women remain mostly normal despite large blood losses up to 5 liters. So standard lab test takes about 60 minutes to become available. So and provide historical information, which I earlier alluded to, but coagulation in patients may be dynamic and unstable. And cross fibrinogen test is predictive marker of PPH progression, while PT and APTT are less useful. So we need to understand that timely golden tool for hyperfibrinolysis, modern PBM can avoid overtransfusion if you do your point of care diagnostics. So here I just want to draw your attention to the support from transfusion medicine who can assist you in managing this kind of complicated cases. As we all know, the decrease of fibrinogen is an early predictor of the severe postpartum hemorrhage seen in this trial, which is a very famous Charbit trial, in which they have seen that falling fibrinogen levels are very sensitive to the amount of blood losses, very sensitive. So we need to add on very, very early FFP, but FFP giving large volumes is not really beneficial. So there is a role which is coming up for reconstitution of synthetic fibrinogen concentrates. Fibrinogen is available to us and it is being manufactured by companies like Intas, and they can be reconstituted, and a reconstituted solution can give you the required volume required which can substitute the falling fibrinogen levels. And if the fibrinogen levels are brought up, there is a chance that woman will start clotting and she will be benefited. There is not much role of octaplis, that is the vitamin K dependent factors, and we are still awaiting more studies whether it will be beneficial in postpartum hemorrhage. But some centers are using fibrinogen concentrate where the availability of FFP or large volume of FFPs are required, and you are fearing the risk of trali and taco. So If there is refractory bleeding, there is a place for use of factor 7, which requires prerequisites like fibrinogen cutoffs, platelets, temperature, and pH, which is mostly very, very difficult to achieve in a woman who has lost significant volume of blood. In my clinical practice, there was only one time when I could use this, where I could have, where I achieved all these, but I didn't save the patient. So it's a very costly molecule. So whenever you're using, be mindful that it is only indicated in refractory bleeding once you have attained these parameters. There is a role for IVR we have just discussed, and your emergency ORs should be very well prepped. And do not forget to remember that all these women who have undergone so much of so will require intensive care. So have you spoken to one? Have you asked for a bed? Or do you know where she'll go? Because she will have febrile morbidities, she'll have AKI, and then she may even have a death due to sepsis. So, summing it all up, I would say that the key management strategies for optimizing hemostatic management in patients with life threatening hemorrhage is nothing but identifying them early and starting a strategy which is focusing on hemostatic resuscitation, early administration of tranexamic acid, frequent measures of hemostasis, send for the lab test and don't go on the historical, values, and ensure goal-directed hemostatic resuscitation. You should rapidly transit to one, and then understands the plan for surgical control of hemorrhage. Thank you very much. And I just want to tell you that FIGO has declared 5th October as End PPH Day in their last meeting, which was held in Cape Town. So I request that Society of Anesthetists of Maharashtra should also focus on something like this rather than prevent PPH. It is End PPH now. Thank you so much. So can I stop sharing
Ex-
my screen? Yeah. Thank you.
Yes, thank you,
Excellent,
madam. Stop.
excellent, Kajal. Lovely.
Thank you.
And I think you brought in you were bang on when it came to letting everyone know the importance of using the Meo's chart in the especially when you in a patient who you suspect that you may have an obstetric hemorrhage, and also the emphasis on accurate estimation of blood loss. That was so important, that one has to accurately estimate it and just not let eyeball and assume that the patient has only bled this much. And another thing which you said was eternal vigilance, which is so important in these patients, and importance of giving calcium. So,
Correct.
and use of fibrinogen. I think we all should wake up to use of FCCs now. Having known that, it has got, we can avoid overload, fluid overload, and it doesn't need blood group, cross matching. It doesn't need any matching. And also the fact that just 1 gram can raise the fibrinogen levels from 25 about 50 milligram per deciliter. So that's quite a lot, knowing that we have to maintain the fibrinogen at least at 200 milligram per deciliter. And I think this FCC has made a lot of difference in the outcomes of patients. Uh, Only few things I wanted to add to whatever you already said. Um, just that if we know that it is a patient is having a placenta accreta spectrum, and just that we have to be warned and be prepared and schedule well enough by 34 to 38 weeks, and and also give steroid prophylaxis. So that is one important point I thought, and also that, as I said, you have to warn the blood bank, the labs, the specialists, and in your OT you have to be prepared. Keep your vasopressors ready, keep warmer ready, keep equipment, pressure bags, all those things which you need, which you can anticipate, and when you have to start treating a hemorrhage, all that has to be there. And most importantly, have another anesthetist who can help you.
Absolutely.
I think that's the
Very
message.
important.
It has to go.
Okay.
When you have a bleeding patient in front of you, please involve one more person, one more head, one more hand will make a lot of difference. That's all from my side. Sir,
Yeah,
from
yeah.
as an
Excellent talk.
obstetrician, I'm sure you must be having some more thoughts.
Yes, yes, yes. Well, excellent talk, madam. You have summed up all the details very finely. Two to three things from my side. Anesthetist is the I feel that he or she is the first line of defense, because first line of defense against obstetric hemorrhage usually is said to be the obstetrician. But from my perspective, from an obstetrician's perspective, what happens is that obstetricians usually go in a denial mode कि ज्यादा पीपीएच नहीं है, ज्यादा ब्लीडिंग नहीं है, because this is a inborn instinct of any surgeon, not only an obstetrician but for any surgeon. So I think it is better to err on the side of positivity rather than allow the patient to deteriorate and then do these all these measures. So my first point is that all of you are aware of who your obstetrician is or what the surgical skills of that obstetricians are. Okay, so please ensure that you pick up the patient at an earlier stage. The moment the obstetrician starts shouting on the nurse, the moment the obstetrician says कि AC बढ़ा दो, temperature कम करा लो, moment the obstetrician starts throwing the instruments, then that means that there is something wrong on the table. So that is the first alert line you can say. In our language, we have a partogram where we have the alert line and the action line. So that is the first alert line कि ठीक है bleeding कुछ हो रहा है या सर्जिकल कुछ कॉम्प्लिकेशंस हो रहा है क्या, फर्स्ट थिंग दैट यू हैव टू सी. नंबर टू इज एनकरेज योर obstetricians to practice the art of internal ileocardial ligation. What happens is in our PG curriculum, the internal ileocardial was never taught to us, or taught to us in a very rare occasion. So wherever you go as an anesthetist, please encourage all your obstetricians to learn the art of internal iliac artery ligation. So this is my point number two. And my point number three is that to arrest or to manage surgical management of PPH, tell your obstetrician at least to have the vascular clamps. We have that Debocki clamps or the Satinsky clamps. Now we in our workshops are telling all our obstetricians to have the Debocki and the Satinsky's clamp. So even if you do not know the art of internal iliac ligation, even if you clamp the common iliac artery, both sides common iliac artery, all of you are excellent anesthetists. You all know that all our orthopedic colleagues, they do tie the tourniquet when they do a lower limb surgery, and the tourniquet is tied for about 40 minutes. So even 40 minutes is a good enough time before any gangrenous changes start occurring. So even if you clamp the common iliac artery using the Satinsky or the Debuchy clamps for say about 15 minutes, that buys you a very good time to call other anesthetists, to call other obstetrician to help. So I think these are the few points which you must emphasize on your obstetricians, because obstetricians, they may not know, or they may not realize, or they may go in a denial mode. Okay, so anesthetist should take lead at that time and then tell कि बाबा बस कर अभी, इसको बुला, या ये क्लैंप लगा, या कुछ तो शिफ्ट कर. Okay, so I mean that is my 2 cents from this talk and for the next talk. Thank you so much.
So very well said, sir. I think you rightly said about, when the obstetrician starts, getting agitated, that's the time when you know that everything is going wrong out there. And what I thought again was team coordination and communication is so important at this point of time, because the obstetrician probably may not even know how much has the blood loss. So it probably the anesthesiologist who has to keep communicating with the obstetrician to tell them how much is the blood loss. That was one thing. And sir, you're in Pune, so I've heard that one Dr. Joshi, he's the pioneer in clamping the aorta
Yeah,
for
yeah. So
these
what?
obstetric hemorrhage. Is it true?
Yes, he is Dr. Vivek Joshi, and the obstetric clamp was popularized by Dr. V.P. Paili from Trichur in Kerala. But Dr. Joshi does, yes, he does practice the aortic clamp in many patients of placenta accreta spectrum. And clamping the aorta is a very, I mean, it's an advanced stage of surgery. Okay, wherever you get a surgical expertise, that's a very advanced stage. But what I'm saying is a very simple thing. Clamping the common
Oh,
iliac artery is extremely simple. And even if you have these two simple Satinsky clamps ka cost is just 1,600 rupees at any center. And you are working with many vascular surgeons or many cardiologists. So they will easily tell you that the clamping the common iliac is the most dumbest thing that anybody can do without any surgical expertise. Without any surgical expertise. So even if you don't have anything, at least buy those two clamps and clamp the common iliac and call for help if at all you are not good surgically. But as you rightly said, yes, clamping the common iliac, we are teaching. We have got excellent videos on common iliac artery clamping or the aortic clamping. And Dr. Vivek Joshi, yes, you rightly said he is one of the pioneers in doing this surgery in Pune. But now many people are doing it.
So, Dr. Indrani, there are two things here. One thing is like we must start partnering with transfusion medicine.
Yes.
And they help us a lot because they guide us how to go about this coagulopathy. And number two, there are recommendations for direct external compression or internal with a fist of aorta. See, we are talking about
Yes.
all type of
Yes.
settings. So in some settings, we will not get this Dr. Joshi.
Yeah.
So we will not get a vascular
It's
surgeon.
correct,
fine.
correct.
So
Yes.
we need
Yeah.
to understand that there is a role of direct compression as well. So you have to stop the bleed right from the top. So there have been
Right,
instances where people have actually compressed from the top if there was any space there, or
right.
internally if they could not. That's the most raw form of doing things.
I
And
know.
then there is something called resuscitative balloon occlusion of aorta, which we all know, RIBOA. So temporizing measures can happen with this, but they have their own drawbacks because you are cutting off the supply. So these are only temporary measures. But yeah, life saving. So a vascular surgeon and a transfusion medicine should be your friends along with the others. So we have partnered with transfusion medicine at PGI. So whenever there's a massive hemorrhage going on, we do ask them for reading out the coagulation reports and telling us what should be given next.
Okay, I'll ask you one question. Leave all the books, leave all
Mm.
the thing apart from your
Guidelines.
experience, you tell me. How will you rate the balloon using a balloon, INR, you having the IVR people to do it? Do you think it helps a lot
Internal
in
iliacs, internal
preventing
iliacs,
hemorrhage in a
inter-
PAS, placenta accreta spectrum?
internal iliacs, no?
Yes.
Yeah, it does help.
Balloon.
In our
What has
practice,
been your experience?
no, in our practice, we are not using.
Huh.
The preemptive balloons are not kept in our setting. But yes, Dr. Sunil in Hyderabad and all, they are using it.
No, we are
Our,
in KM hospital, we have been using.
no,
But
we are
let
not
me tell
using
you
it.
very
Preemptive.
frankly, I have not found
No, they are not
much,
using it. Our
advantage,
center will
sir.
set for,
I can ask our expert to tell us what has been your experience.
so we are
In
mostly sending for
the
DSA.
textbook will tell you that it is going to help you,
We are not putting it.
but practically, to tell you the truth, I have not found much of a difference. That's why I asked you, Kajal. You also
No,
must
no, we
have
are not using.
been.
We are not using. And it's only, based on the DSA. Patient is
Hmm.
sent to DSA. If there's a blush, then they will put the glue. And we are not doing a preemptive internal iliacs. We are not.
KM, we are doing preemptive.
Mm.
Kiran sir, what about you? What
Uh,
is your
well,
opinion on
well,
that?
yes. There are people who have tried this particular thing in the already diagnosed case of placenta accreta spectrum, wherein they
Hmm.
do the occlusion and then they carry out the hysterectomy. But they carry out the hysterectomy straightway. They don't save the uterus. So my take home for this will be it is better to do a obstetric hysterectomy instead of waiting for all these things to happen and losing
Hmm.
the patient. So yes, aortic clamping, or as you said, as you rightly said, the occlusive balloon. Uh, not much articles have been published till date, or many of the people in Pune at least are not doing this. I have heard a few cases in Aurangabad where Dr. Gadappa is doing that thing, where they have interventional radiologists. There are quite a few people who are practicing, who have got interventional radiologists, but they are doing it in Gadinglaj, in a small city, in a small town, Gadinglaj. There they are trying to do it, but sufficient data is not available to prove that it is good enough. You need at least about say 50, 60 cases before you say that okay, it is good or it is bad. So sufficient data from one center collect is not available, and collectively you can't rely on scattered evidences that okay, it is good or it is bad.
So the textbook and the recommendations say that it is helpful. But practically, what I have experienced, I'm telling you, that I have not seen much of a help actually.
Avinash
Yes.
sir, are we going to take the questions now or in the
No,
end?
no,
नहीं
no.
नहीं
I
after
know there will
after
be,
the
there
After
are
the
so
next
many
talk.
questions
Please,
will
I
be
think we
there.
can finish the questions because then I will have some time to do something else. Otherwise, mostly we have covered. If there
Yes,
is any other unanswered question, I'll
yes.
just have a
We
look.
will take,
Then,
we will give
Kajal, can
5 minutes.
you just write down the answers on the chat box then?
Okay, I'll do
Yeah,
that.
there is one question. How much of fibrinogen concentrate to be given and what is the cost?
It's about right now it's about 20, I think roughly around 15 to 20,000, and you have to constitute it with the 20 mils. It gives you 20 per cc, so 2 gram, 2 gram. So 2 gram you can give.
2 to 4
Madam,
grams
just
Yes,
IV.
yeah,
One
2
vial
gram.
will contain 2 grams.
Yeah.
okay. Madam,
So is there
initially you
any,
said, sorry, sir.
yes,
Avinash sir,
is there
continue.
any use or have you used this non-pneumatic anti-shock garment
So
in
those are
practice
mostly for
medicine?
transporting women because again they are like
Okay.
external tourniquets. So yes, there is a role for those places where you do not have access to, control the bleeding. There is a use of anti-shock pneumatic garments. Yes, there is, and
Said
they're not
ma'am,
very costly. They don't cost much, and they're in
yes,
piecemeals. Like you can tie them on the arms separately, like how you go for
yes,
swimming. So you just have to tie on one arm, legs, and there's a
legs.
yeah, legs exactly.
And
So we normally when we do a PPH drill, we always keep that to
Yes.
show all the audience, because as I said, there are 180 people in audience today. Some of them may not be having access to everything, so that's a good thing to keep.
no, actually, they are very helpful when you have to actually shift the patient
Yes,
to a
yes,
center of excellence.
excellence,
You can't
correct.
do it in small nursing homes. Now, once the
Yeah.
patient has started bleeding and now you need, hysterectomy and, more blood and critical care and all that, that's when, these garments and all will be of real help, especially when you're transporting the patient to another hospital of excellence.
Okay, thank you,
Kajal,
madam. Madam, you said that there is a no use of prophylactic tranexamic acid.
That's
So we
what the
are
guidelines
regularly
say.
giving,
If
yeah, we are
so
regularly
many of
giving,
sorry.
yes, yes, we are regularly using this as a prophylactic. So is it of use or no?
Dr.
Not.
Kiran is here. He can let me know. But the
Yeah.
latest there is no recommendation for prophylaxis. But actively bleeding, yes.
So yeah, for we do use this for prophylactic cesarean section when we do a
Yes.
C-section. Yes, it does reduce the amount of flow during the C-section as well as post-op also. It does. But I mean, as far as PPH is concerned, I don't think that it has got any role in PPH per se.
Yeah, the crash and the women trial have proven that tranexamic acid helps. But as a prophylaxis, how it will help, that may not be a thing. But once you know that the patient
So
has gone beyond 300 ml of blood loss, I think we have to start
yes,
using it.
correct.
And what
And
That's
about
there are some
vitamin
downsides
K?
also to tranexamic acid. It is also causing thrombosis. So are we monitoring
true.
our women? We are not
True.
monitoring. So just don't
No.
hang it there because you are feeling supported yourself. It
Yeah.
doesn't help many of them. It may help one or two, but that is what they said. Number needed to
Yes.
treat. So they
Uh,
don't justify.
So, Kajal, but what I would also say here, because so many people are watching, if you have to err on the giving side or not giving side, I would still say err on the giving side. You give it.
Yes.
See, we have to talk evidence-based. Clinical practice can vary from patient to patient and from clinician to clinician.
Exactly.
So there are
So,
no
but then the
nothing.
women's trial and the crash trial have proven it's
Is
very
3
helpful.
hours, within 3 hours. Even if you give, say patient has bled, was bleeding since morning, but now you at 4 o'clock in the evening you thought I should give tranexamic acid. Be aware that the percentage of beneficial effect has gone down several notches. So even the crash trial said
So,
first hour,
early
you give
use.
yeah,
So,
1 hour
it's talking
fast,
about early
30%.
use of Tranexa.
Yeah,
The
correct.
crash trial is
So
saying
with
that.
each hour, it goes down by 30%. So after 30%, it is only 10% beneficial. In the
Yes.
crash 3 trial, they're very clear
Yes.
about that.
Yeah.
So that is why I said if you
Right.
have to use it, use early.
Yes.
Use
That's why I
early.
said you
Madam,
can
Don't
err
wait.
on using side rather than
Early, if you
err
have,
on not using side.
see, Indrani, that is why
yes.
they have changed from 500 mils to 300 mils.
Yes.
So
So,
they are saying,
Kajal madam, I wanted to ask that actually. See, twice you have said, once you have said that now for high risk patients, it is 11 gram percent hemoglobin that we are accepting. So, like if it is say 9.5 or 10, should I transfuse the patient or
no, no,
ask
no,
for
no,
blood?
no. No, no, no. This all is to increase your vigilance. That
Okay,
the
but
woman
not
who has 10,
transfuse pre-op.
no, 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 no. Transfusion triggers are 7 grams. But they're saying in
7
the
grams.
antenatal period, build up the mother to tolerate the blood loss more than to start, deteriorating early. So earlier, 10 grams in antenatal period was good enough. But now they're saying focus on 11 so that women has a bigger window of opportunity to deteriorate, so get better. So because
La-
poor
Mhm.
HP is also not good for wound healing.
Yes.
Yeah, and Dr. Umesh sir is asking whether you can highlight on maximum doses of uterotonics, and Dr. Ramchandra sir is asking whether gel embolization of uterine artery is
I
possible.
think this is Dr. Kiran's questions. Maybe sir will be able to answer that.
No, as far as as far as the gel embolization is concerned, okay, we are you living in a utopian world. I mean, if everywhere interventional radiologists are not possible, is not possible. Only if at all you have, then there have been people in Ruby Hall, for example, in Pune city, where they are trying gel embolization and they have succeeded. Now, as far as the maximum dose of uterotonics is concerned, I think if at all we are looking at injection prostadine, one injection, say every 15 minutes, maximum up to eight maximum up to 8 injections, so that is the recommended dose. But before that, I think misoprostol 600 milligrams sublingually, that is the first line that you can take before giving other uterotonics like prostadine or any other ones.
Madam, how we should proceed for the if patient is posted or decided to for the obstetric hysterectomy. Before that, what we should take care?
Oh, as I said, that we can go through the chart which they've given for the low risk, high risk, medium risk, that the three categories. And if your patient is, say, for example, let's assume she's a case of placenta creta. So I know that placenta creta percreta, they're going to bleed a lot, as Dr. Indrani have very nicely highlighted. First and foremost, have a senior person on floor because you are not going to need help, and then go with all those massive hemorrhage protocols which I had highlighted, the 70s. So you should have a large bore cannula. You don't need a central line, and but you prepare your war zone. You prepare your war zone. But if it is unanticipated, then again vigilance. Key factors are vigilance, and then uh, you know um, team preparation and activating that
MTP protocol.
yeah, so in which you ask for help. So asking for help, who is going to be coming to your help? And if you think it's a placenta creta but you do not have the facility, please refer the patient to a center of excellence, because nowadays some centers are being labeled as centers of excellence. So it is better to go ahead with that than to get so many of your coronary constrictions, because
Yeah, it
these
should have a
patients
critical care. It
yeah,
should have a
so
critical
so
care.
and as I had said, these women will also require interventional radiology at certain point of time, maybe intensive care units. So if you think that patient has been labeled as medium or high risk and your center is not equipped enough, better to refer early.
Should we intubate the patient then? proceed with the
Dr.
spinal
Avinash, that
incision.
depends.
Yeah.
Every
Yes.
anticipated OH patient need not get GA.
Yes.
Okay.
Okay.
So you can start with, but you have to explain this to the patient before itself. That
Also
I
depends
will
upon
be
the
giving regional spinal anesthesia, but you may need general anesthesia later. So that
uh,
information, that consent has to be there. So every patient need not go for general anesthesia, but then,
expertise
you have to
of
have that
expertise of the
preparedness. That's
surgeon is
all.
also very important. Expertise of the surgeon, operating surgeon, is also very
Yes.
important.
I think we should stop here for this discussion for this session. We will proceed to
To our
The
our
next
next.
next lecture.
lecture.
Yes.
The
I request
question
Dr.
will not
Manisha
end.
Shembekar to proceed for her lecture. Hello, Manisha.
Yes, yes. I'll just
Ah.
share my slides. Yeah. Are they visible?
Yes, yes, madam.
Yeah. So, respected chairpersons, Dr. Indrani ma'am, Dr. Kiran, Dr. Avinash Bhosle, President SAMS, Dr. Sheetal Dalal, Honorary Secretary SAMS, Dr. Shilpa, Dr. Rajesh Tagadpalle, Dr. Vikas Karne, Sachin Chandolkar, and all the office bearers of SAMS. A very good evening to all of you. I'll be speaking on management of hypertension with vasopressors during C-section under spinal anesthesia. First of all, I'll extend my gratitude to SAMS and the office bearers for giving me this opportunity. I bring greetings from Omega Hospital, where I work along with my team of directors and anesthesiologists. So my talk is specifically based on the guidelines, which are international consensus statement on the management of hypertension with vasopressors during cesarean section under spinal anesthesia, published in 2018 by Kinsella Carvalho et al. So why were the guidelines developed? Actually, there were a few recommendations by ASA Task Force, NICE, and Society of Obstetrician and uh, mm, Perinatology, but they had given only the recommendations, and they did not have specific guidelines in all the settings. So, since there were multitude of options available, so these were developed to give specific best practice plans which cover drugs as well as equipment, and recommendations are made for resource rich as well as resource poor settings. So, the overview of my talk will be definition of hypertension, what are its consequences, we treat hypertension, non-pharmacological methods, and use of vasopressors. So, how do you define hypertension? Kohler et al. Found 15 definitions in 63 studies. So, he said that there are absolute blood pressure values, that is systolic pressure less than 100 millimeters of mercury, or a decrease from 30% of the baseline, or systolic arterial pressure of less than 80% of baseline, or a combination of these is defined as hypertension for the parturient. Systolic arterial pressure, although less important determinant of organ perfusion than mean arterial pressure, was the determinant in most of the studies that were done. Now, arterial blood pressure increases during labor, that we all know. So baseline blood pressure may be higher when the patient is brought to the operation room. May it be an elective surgery, or even if the patient has been in labor for some time. So for example, I've shown here monitor which shows a blood pressure of 163 by 81 in a previously normotensive woman. Hence, values in the antenatal period or values taken in the ward or beginning of labor should be considered as baseline values. And if we do so, it will reduce the incidence of recorded hypertension. Because if I look at the monitor and see that her blood pressure at the beginning was 163 by 81, then I will feel that the after spinal anesthesia, hypotension has occurred, whereas her baseline values were much lower in the before she went into labor or when she was in the ward. Now, what are the consequences of hypotension? First and foremost is nausea and vomiting. Acute hypotension reduces the cerebral perfusion, and there is transient brainstem ischemia, which activates the vomiting center. There is transient cerebral hypoxia. So, near infrared spectroscopy shows that hypotension causes significant decrease in the maternal regional cerebral blood volume and cerebral oxygen saturation. Hence, these women will benefit if supplemental oxygen is given to them when they are in the operation room. Spinal anesthesia reduces splanchnic blood flow by 20% as it is, and it is accentuated by accompanying hypotension. So, splanchnic hypoperfusion releases emetogenic factors like serotonin from the gastrointestinal tract, and along with that, there is an opposite blockade, which causes vomiting. So, what are the effects on the fetus? Animal studies show that sustained decrease of more than 60% uterine blood flow causes significant bradycardia and acidemia within 10 minutes in a previously uncompromised fetus. Neonates of women with spinal induced hypotension had significant acidosis, and hypotension lasting for more than 2 minutes causes increase in the umbilical venous oxypurines and lipid peroxides, which is suggestive of ischemia reperfusion injury. So, maternal hypotension, which has lasted for more than 4 minutes, is associated with neurobehavioral changes in the neonate, which appear at 4 to 7 days of life. They have recommended that duration of hypertension is more important than the severity. So, we have to keep it as low as possible. Now, coming to the cardiovascular changes after spinal anesthesia. So, we all know that the primary effect in a healthy woman is decrease in the systemic vascular resistance due to small vessel dilatation by the sympathetic blockade. So, there is compensatory baroreceptor mediated increase in the heart rate and stroke volume to increase the cardiac output. However, in certain cases of high spinal block, sudden bradycardia, that is basalt gyrus reflex, is activated due to vagal stimulation. So, in such a situation, aim of vasopressor is to restore the systemic vascular resistance, which is done by agents with alpha 1 activity, and hence those agents which have predominant alpha 1 activity are preferred. Now, what are the non-pharmacological methods? So, methods to reduce, these are the methods which reduce the compression of the inferior vena cava or reduce the venous pooling in the lower extremities. So as to push the blood in towards the heart. So as we all know, left uterine displacement, 15-degree angle, leg compression bandages or antithrombotic stockings. We were talking about the non-pneumatic um, uh, bandages just now, but these are not indicated here. Crystalloid colloid co-loading, and I have said some of the studies have given 500 ml preload of 6% hydroxyethyl starch followed by 500 ml of ringalactate. However, I would like to add here that preloading is no longer recommended. We all go for co-loading, which is crystalloid co-loading. Now, what are the vasopressor agents that are routinely used and how do they act? They act on the beta 1 and beta 2 adrenergic receptors, and physiological effects of each of them differ. So, this is a comparative charts of all the vasopressors. The most commonly used and recommended was ephedrine earlier on, which acted more on the beta 1 and beta 2 receptors and had a weak alpha activity. It acted indirectly on these receptors and had a weak direct action. Onset was slow and duration is prolonged. Since we do not want any positive inotropic effect, ephedrine is no longer recommended. Phenylephrine, which has an alpha 1 activity, acts directly and has an immediate action. Duration is intermediate, is recommended. If you consider all other options like metronidazole, adrenaline, and mifentamine, you find that all of them have alpha 1 as well as beta activity. I have added mifentamine. I've highlighted it here because it is a drug which we all have in our operation theaters, and we most commonly use it. And it is, I think we are not wrong in using it because it does have an alpha 1 activity, but beta activity is also there. So, and it has an indirect action. It, although it acts immediately, there is a prolonged effect. Now, there was a study done by Dyer et al. Who used Lidco monitors to measure the cardiac output, and they found that phenylephrine corrected post-spinal decrease in blood pressure more effectively than ephedrine. And heart rate, and not the mean arterial pressure, is said to be the best surrogate for cardiac output. So if you monitor heart rate diligently, it means that you are monitoring the cardiac output, because we do not have all these monitors. Now the question arises whether you should treat hypertension or you should prevent it. So many of the studies which have come up uh, compared prophylactic versus reactive treatment with phenylephrine. And this study by M. Hisen et al. Says that prophylactic phenylephrine has a benefit with regards to incidence of hypertension before and after delivery, as well as to prevent nausea and vomiting. Now, how do you manage the vasopressors for elective cesarean section? You should take 2 to 3 baseline blood pressure measurements. If the blood pressure is high in a non-hypertensive woman in labor, as I already said, and measure the blood pressure every minute after instituting spinal anesthesia. Now, whether you should give infusion or bolus. Uh, Continuous infusion of phenylephrine is superior to bolus doses. Doses of 50 to 100 micrograms are widely used. But a word of caution, because if you start delaying the start, delay the start of infusion, it limits the efficacy in reducing incidence of hypertension. Because if after giving spinal you go on to prepare the infusion and start it, so much of time will be lost that patient definitely will land up in hypertension. And by the time your infusion starts, the duration of hypertension which will be much more. So you have to be ready with the infusion beforehand. So the corollary is start infusion immediately after spinal. You give spinal, make the patient supine and start the infusion. Now ephedrine, it used to be the first line drug to treat hypertension in cesarean section until recently. However, fetal acidemia increases in labor that we all know, and ephedrine has shown to cause dose-related acidosis as it crosses the placenta and is associated with increased fetal concentrations of lactate, glucose, and catecholamines. Hence, phenylephrine is the best choice if we compare it with ephedrine. Now, women with preeclampsia. Patients with severe preeclampsia experience lower vasopressor requirement because they have greater endogenous vasoactive mediators which are circulating, and they are more sensitive to exogenous vasopressors that we are giving them. So if we compare them with the healthy pregnant women, these women will require less doses of phenylephrine. However, rapid reduction in systolic arterial pressure decreases the uteroplacental circulation, and it should be avoided. Now, women with cardiac diseases. Again, here, phenylephrine is said to be the agent of choice, especially in women with hypertrophic cardiomyopathy, because there are no inotropic effects in contrast to ephedrine, and intrinsic beta agonist activity of ephedrine worsens the dynamic ventricular outflow obstruction. And it is also preferable in ischemic cardiac disease where tachycardia should be avoided to minimize the oxygen demand of the uterus. But for regurgitant lesions, ephedrine is preferable because we know that bradycardia should be avoided in these patients so as to prevent the regurgitant flow. So these are some recommendations for patients with cardiac disease. Coming to limited resource settings, we should carefully assess the volume status in cases of emergency. Start crystalloid co-load with ringer lactate or 0.9% normal saline in 15 ml per kg, and fixed low rate phenylephrine infusion with supplementary boluses. I'll enumerate it in some of my later slides. Now, if a patient has hypotension and tachycardia, what you give is alpha agonist, that is phenylephrine. If along with hypotension there is bradycardia, you give alpha agonist as well as anticholinergic drug like atropine or glycopyrrolate or ephedrine. If there is persistent refractory hypotension, then review the cardiovascular status of the patient. If there is and consider whether patient has hypovolemia, you need to infuse more fluids. Or if there is cardiac disease or cardiomyopathy which has been missed, or if there is preeclampsia induced cardiac failure, which should be ruled out if it is not responding. Now, if there is high spinal block with cardiorespiratory compromise, aggressive treatment to correct the cardiovascular compromise should be done. Now, how do you prepare this vasopressor solution? Add 10 milligram phenylephrine to 100 ml of normal saline. The concentration becomes 100 microgram per ml. Draw it in a 50 ml syringe and attach an extension line. Start warm crystalloids with 14 to 16 gauge IV cannula. Connect an infusion through a Y connector. And continue monitoring of blood pressure every minute. Start the infusion at 15 to 30 ml per hour, which will be 25 to 50 micrograms per minute, and adjust the infusion to maintain the systolic pressure to more than 90%. If hypotension occurs, that is systolic pressure less than 90% and heart rate is maintained, increase the infusion by 10 ml per hour. If the systolic pressure is less than 80% and the heart rate is maintained, add bolus of 100 microgram and increase the infusion. You should add bolus in these cases because infusion will take time to act. And as I said, if there is bradycardia along with hypertension, either you give 3 to 6 milligrams of ephedrine if the bradycardia is not much, but if the heart rate is less than 60, you need to give atropine. Now, in resource limited settings, it is recommended that you give 10 milligram of phenylephrine in 200 ml normal saline. Concentration becomes 50 microgram per ml. And if the syringe pump is available, start infusion at 30 ml per hour. But if there is no pump available, give boluses of 50 to 100 micrograms. Or you can add 500 micrograms of phenylephrine to first liter of ringer lactate solution and administer it rapidly in 10 to 20 minutes, which will equal to 25 to 50 microgram per minute infusion roughly. It will not be very accurate, but that will be roughly given to the patient. Now, there are a few acceptable alternatives. Ephedrine, as you all know, metrominol, 10 milligram diluted to 20 ml in normal saline and administer 0.5 milligram boluses. Noradrenaline, again, is maybe a reasonable alternative, but using such a potent drug out of ICU setting has its own concerns, especially in a peripheral line. Adrenaline may be used whenever required. Now, what is the future? They say that computer controlled vasopressor administration can be done. It is a closed loop automated vasopressor delivery system which uses microprocessor based control unit to vary the dose according to the maternal blood pressure. I think we still have a lot of time to reach there. Now, what is the take home and what are the best practice recommendations? Hypotension after spinal anesthesia causes both maternal as well as neonatal adverse effects. Vasopressors should be used routinely and preferably prophylactically. Alpha agonists are the most appropriate drugs with some beta activity, may have best profile like metrominol and noradrenaline. Left uterine displacement with fluid co-loading along with vasopressors is recommended. Aim is to maintain the systolic pressure to more than 90% baseline and avoid less than 80% baseline by starting phenylephrine infusion at 25 to 50 micrograms per minute. Maternal heart rate can be used as a surrogate for cardiac output. Small doses of ephedrine are suitable if heart rate is low. Use of smart pumps and double vasopressor infusions have greater stability than physician-controlled infusions. Women with preeclampsia develop less hypotension. Abrupt decrease in systolic pressure is undesirable in these women, and women with cardiac disease individualize the treatment, assess. However, phenylephrine is the best. I come to the end of my first talk, and my second talk, if you allow me, I'll continue with this, which is neuraxial adjuvants for cesarean section. Should I go ahead?
Yes, ma'am. Please continue.
So, mostly opioids are the ones which are recommended. In previously, only opioids were given, and epinephrine, of course, in some of the cases. Why opioids? Because it reduces the dose of local anesthetist, it improves intraoperative and postoperative comfort, it augments the quality and prolongs duration of analgesia, and decreases nausea and vomiting. Now, whether you should give morphine or fentanyl, lipid soluble or water soluble, which is better? And there are a few clinicians who use both. First, for the fast onset of lipid soluble agents like fentanyl, and for prolonged duration of water soluble agents like morphine. Here, as the graph shows, fentanyl will have a rapid onset and offset of action, while morphine will take some time to act and will have a plateau action, and they have a good transition so that patient remains pain-free for a long period of time. So spinal dose of fentanyl is 10 to 25 micrograms with bupivacaine or ropivacaine, and it is said that pruritus will be less if the dose remains below 35 micrograms. Dose of sufentanil is 5 micrograms. Now, spinal morphine has a latency of 30 to 60 minutes for onset of analgesia, as shown in the graph. Recommended dose is 0.1 milligram, can be given up to 0.5 milligram. Word of caution, because it may have delayed respiratory depression, maybe up to 18 hours of administration, and respiratory depressant effect outlasts the antagonism by naloxone, which acts for 90 minutes. So we have to be very cautious if you use morphine in these women. Now, the recommended doses are hyperbaric bupivacaine 12 milligram, fentanyl 10 microgram, and morphine 0.1 milligram, or fentanyl 15 microgram and morphine 0.15 milligram. These are doses by Chestnut. Now, I'd like to discuss buprenorphine, which is widely available to most of us, and we use it very often. It's a mixed agonist-antagonist narcotic. It has a high affinity for mu and kappa receptors. Hence, it has high potency, it is lipid soluble, and has long duration of action. It is 30 times more potent than morphine, with an added advantage that it has a ceiling effect on the respiratory depression. So, it really has a good profile, but I don't know why we do not use it more often. Dose is 30 to 60 micrograms. Now, these are the drugs which are routinely used as adjuvants in other situations, like alpha adrenergic agonist, clonidine, in the dose of 60 to 150 micrograms, which improves intraoperative analgesia, decreases shivering, and reduces peri-incisional hyperalgesia. However, it has hypotension, prolonged hypotension, and gives sedation, which is not desirable in these women. And they have given a black box warning against its use in obstetric patient because of prolonged hypotension. Then coming to neostigmine. Intrathecal neostigmine in doses of 100 microgram reduces the post-operative pain with no effect on the APGAR scores. However, there is high incidence of nausea and vomiting, which is refractory to treatment. Hence, it also is not commonly used. Now, new adjuvant that has been tried is dexmedetomidine. It has been tried in all other patients, but very few studies are available in obstetric patients. Intrathecal dexmed 10 microgram reduces opioid use and provides post-op analgesia as well. There is high incidence of hypertension. one of the studies says that there was high incidence of hypertension and hence we need to modify the doses, while another study done by Takalo et al. States that a post-op analgesia is better with no incidence of hypertension. Hence, it requires more studies, and it has not come into recommendation as yet. Now coming to epidural anesthesia for cesarean section. If you have put in a epidural catheter for labor analgesia and you want to convert it into a cesarean section, or you want to give epidural anesthesia directly for a cesarean section, the preferable drug is lidocaine 2% with epinephrine. So epinephrine as an adjuvant here augments analgesia through alpha-1 adrenergic receptor blockade, and it is quite desirable to give it. Either we can use a freshly prepared solution or a premixed solution, which is available everywhere. Then addition of sodium bicarbonate causes more local anesthetic molecules in the non-ionized state and hastens the onset and augments the quality of block with lignocaine, and it should be given especially if we are converting it into a labor analgesia for a cesarean section. However, sodium bicarbonate, if given with bupivacaine, shows precipitation. It has seen that precipitation occurs with longer acting agents like bupivacaine, levobupivacaine, and ropivacaine. However, with lidocaine, it does not cause any precipitation and is highly recommended. So to conclude, opioids still are the popular adjuvants for neuraxial anesthesia and cesarean section. Lidocaine 2% with epinephrine is recommended for epidural anesthesia. Alkalinization of solution by adding 8.4% soda bicarb hastens onset of block. Alpha-2 agonist agents like clonidine and dexmed have been used as adjuvants. They may cause significant hypertension, bradycardia, and sedation, and it is their off-label use and it is not FDA approved. So more studies are recommended to put it into practice. Thank you so much.
Thank you, Dr. Manisha. Over to chairpersons.
Very well done, Manisha. Very well done.
Thank you, ma'am.
Just I wanted to reiterate what you already said about the use of colloids and crystalloids. And definitely co-loading is definitely better than preloading. When it comes to, we prefer crystalloids, but then if you're sure that there is going to be a hypotension, then colloids also can be used. But then we have to understand when we are using starches, you can have a renal or a coagulation issue if you're using colloids. So definitely co-loading is better than preloading, because if you preload the patient, you can have a rapid distribution of the IV fluid into the interstitial space and very little fluid is available when there is hypotension. That is why co-loading is better than preloading. That is one thing which I wanted to say. But then, um, what is even better is use of vasopressors. So remember that when there is hypotension, you have to use a vasopressor. That is number one recommendation. So phenylephrine, as Manisha already said, is the best drug for any obstetric hypertension because of better BP control and less fetal acidosis, which is seen, and better outcomes. APGAR scores outcomes are much better when you're using phenylephrine. But then there is also ephedrine will be the second line. Mefentin also can be used. I think for time immemorial, all of us during our formative days used only mefentin, and nothing happened, to our patients. And it also has the advantage of slightly increasing the uterine tone. And whereas even phenylephrine increases the uterine tone, remember that. So all these drugs can be used, and that's it. So I think otherwise, I think you covered everything about hypotension and how to treat the hypotension and all that. Thank you so much.
Thank you.
Yes.
Kiran sir.
Koti sir, you
Yeah,
want to add?
yeah. No, all points well covered. I mean, this is obviously not the obstetrician's domain, but Dr. Manisha has covered
Mhm.
most of the points. One thing about Dexmed is we have been using Dexmed for practically a year or so, and we have not found any case of hypotension. I mean, your studies mentioned that one studies mentioned hypotension and the other doesn't mention
And
hypotension. So we have not found any kind of hypotension in our patients with the use of Dexmed. So that's
you
about it.
found any advantage
The
Yeah.
analgesia is of a much better quality.
Yes.
for how long?
Analgesia, sorry?
For
How
how long?
long?
How
Oh, for
long?
how long? Say at least for about 6 hours, let us say.
Okay, so other analgesics may not be required.
They are usually not required, and we usually start paracetamol after 8 hours or so.
Okay.
So it is much better, definitely yes.
So there is no
There is
Yes.
FDA approval of all these drugs.
Yeah,
And,
that is off-label use.
because we are not using because there is no FDA approval. And number two, we are recommending phenylephrine. But if you read the practice guidelines of 2016, they write phenylephrine or ephedrine. They haven't told us to do away with ephedrine. The only thing is repeated doses of ephedrine, they cause tachyphylaxis and this fetus beta metabolic activity and fetal acidosis. The dictum today is that maintain blood pressures at baseline. So early use, as you had said, here there is a role for prophylaxis because we are trying to titrate our blood pressures at 90 to 110% of baseline rather than allowing them to drift down to 80% and then start treating. Because that is the time when phenylephrine acts faster as infusion and ephedrine takes a little longer time to act and mephentermine also takes a little longer time to act. So we are trying to set our targets at 90 to 110% of baseline.
Yeah,
That
if
gives the best
is
maternal outcome in terms of no nausea, vomiting,
and the fetal
and
outcome as well.
yeah, correct. Higher umbilical
They have recommended
pH and
amphetamine as the second line also. Like if
no, they are
it,
not saying second line. They are saying we read it again and again to understand. That is why I'm just adding. They write or they don't write as second line. Let us wait for the next guidelines to come. They haven't given the practice guidelines after 2016. They're still awaited.
In new
there's one.
guidelines,
Yeah.
if noradrenaline will come,
Noradrenaline is like they are saying you send a big man for a small boy's job.
okay.
yes,
So
so
it's like that, and then you have to be very mindful of your
especially
peripheral
in a
peripheral
setting,
extravasation. You can use it,
correct.
but there is no
In a
need behind
peripheral
a
line,
tube.
in a setting which is not an ICU setting, it has
We
to
are
be.
using it at times, but it's not the gold standard. It's
Yes, ma'am.
obviously it is a very potent drug, so it helps.
Yeah. Another thing, many of us at periphery and level, they are still using mephentermine. And you said that we are using since so many years, and we have no any disadvantage. So, what is your message to all those who are still using mephentermine?
That is what I told, that mephentermine has alpha 1 activity as well as beta activity. It is similar to ephedrine. Uh, but ephedrine has potent beta activity. So I think there is no harm in using mephentermine, which is widely available. Only thing we have to ensure that the blood pressure does not go down to more than 90% of the baseline.
Now,
And there's one question. Sorry,
mephentermine
sorry.
is now not available easily because of it is used by the bodybuilding and other people.
I don't know. We get it.
See, what has happened is
So
certain
only
drugs
that
are
it causes an
unnecessarily.
increase in SVR.
Yeah. So you
Systemic
maybe
vascular.
it can be
Yeah.
avoided in preeclampsia and otherwise
So
preeclampsia is as such not requiring a lot of. But phenylephrine, I think it's not. It's coming as 2 ml ampule and 10 ml ampule. I think you can transition your
Yeah,
practice.
it is available. Phenylephrine is widely available.
Mm.
No, my
Can
take
you
on
use, Madam, mephentermine as a prophylactic?
See, you have to maintain maternal blood pressures at baseline. So why not use it prophylactically?
So
Because
if
it
there
takes
is no
3 to 5 minutes.
contraindication, you can use it.
Yeah, so 3 to 5 minutes for the action to come for MEF, and in these 5 minutes, the blood pressure will drop down to 70. Patient will become symptomatic. So that's not desirable.
Okay.
Most of our women, they start having nausea and vomiting. So that's simply not desirable. That's bad anesthesia. I Because it is
That is
80%
what.
incidence of hypotension is there. I think Manisha did highlight that. So incidence is very high because of
But
30%
what I feel is,
reduction.
as soon as we give spinal, if we give any vasopressor
See,
and
Manisha,
prevention.
you have to control it. See, the phenylephrines, the only good thing is it's easily controlled. Titratability is better. That is why we use it. Like, you can run the infusion, stop the infusion.
Yeah,
As
that
soon
is
as the
true.
BP is shooting up, you can stop it. So you can control it better. So, like, we are also buying good cars. Let's buy a good drug also. So I always tell residents, if we are having Maruti 800, now we are having Swifts and our good Honda City cars. So we are also transitioning to good things. Why not good drugs?
Yeah, so it is readily available. So yeah, of
Yeah,
course.
we should transition now.
Avinash sir,
Yes,
can
any
we take the
questions?
questions?
Yes,
Yeah.
please.
Yes, we
Yes,
can.
please.
Yeah, so there was one question by Dr. Pratibha, that is phenylephrine to be given recommended in all cases. I think you already answered that. If it is less than 90%, then you start phenylephrine, but the effusion should be ready,
Yeah, yeah, it
right?
should. No, no, recommendation is you start infusion as soon as you give spinal.
So in all the
But
patients,
do
madam.
not wait for hypotension to occur.
Okay, and Dr. Shan wants to know how explain, even I have taken that point, like explain how heart rate is more sync with cardiac output. Here I wanted to ask whether the patients are apprehensive, so heart rate is always high till the baby delivery. And sir says phenylephrine usually brings down the heart rate, although the MAP is ensured. So is reassuring. So like you had said at one point of time in the
So
discussion.
this is what the study said when they use that Lidco monitor to assess the cardiac output. They found that mean heart rate was if they maintained the heart rate, that means the cardiac output was maintained rather than the if mean arterial pressure. So it went hand in hand with the heart rate. The cardiac output went hand in hand with the heart rate rather than the mean arterial pressure. That was the study which said that.
Yeah, but mostly the heart rates are very high, like they're
Yeah,
anxious.
initially when that is what they say, the baseline blood pressure also is very high, and because of the anxiety or pain if the patient is in labor, the heart rate also will be high.
Dr. Shan also wants to know that when we are adding fentanyl and morphine, how are we giving it in separate insulin syringes or back to back or mixing, or how do you recommend?
They're given in separate syringes, 1 ml syringes, so that they give exact amount of the drug. Those
Means
in
you have two tuberculin syringes, one fentanyl, one morphine,
Yeah.
and then you
And
have the third syringe which has bupivacaine. So, and what is the sequence of giving?
frankly speaking, I do not give morphine.
Okay,
But that
suppose only fentanyl, how do you give? First fentanyl, then
if
bupivacaine,
I
or
give only fentanyl, I mix. But this is what the recommendation is given by Chestnut, that they give
okay.
different syringes, give bupivacaine followed by fentanyl and then morphine.
So normally, I
So,
think we all mix the either
yeah,
butyrin
we are
or
mixing.
fentanyl.
We are also mixing. I think it is becomes too much of a, dilutional
I
hassle.
know.
So it
No,
is
and
better to
not
mix
only
and give.
that, see, the pain is not all that much. The
Mm.
phalanx steel incision is not that painful. Come on, we don't need morphine for that.
We do not need it, but that is what.
Yeah, I don't think it's like, overdoing
So
it, I think.
Do every one of you give
All
suppose?
Indrani, all Western women are very sensitive. They all give 100 mics of
Our
morphine.
women
Our
tolerate
women are more
pain.
tolerant, and
Yes.
and
you have to have your
they have
safety
to
network also.
they
Once you are
have to
giving
go home the
intrathecal
next day
morphine,
also, because ERA's protocol, they have to go home and they have to vacate the bed So many other things are also to be taken into account.
We use
Are there any?
suppositories. Is anyone using
That's good.
suppositories?
Yeah, they're very
Yes,
good.
Yeah,
we are
yeah.
using
I
suppositories.
give diclofenac and tramadol
Diclofenac,
suppository.
They're
diclofenac,
Yes.
good.
and yes, we are using.
Most of us
Avinash sir,
using that.
Avinash sir, you were saying
Yes.
Just,
something.
Along with
just
Yes.
tell.
steroid. So
How
we give
much the?
multimodal. Obviously, we all give multimodal. We give buprenorphine, we give NSAIDs, especially suppositories, and we give tramadol, we give paracetamol as that is
Yes.
what.
Tab block.
And
Why leave
Tab
that?
Yes.
block.
Tablet.
tab
Yes,
block.
ma'am. Tab block is very.
How much is the prolonged hypertension incidence is there when we are giving these adjuvant, because we don't have this facility or monitoring at periphery level.
No, it doesn't
So
add to the hypotension. No.
Rather, the bupivacaine sparing effects decrease the incidence of hypotension with fentanyl. It's on the other hand side.
no, with
You add
clonidine.
fentanyl, the effect incidence of hypotension decreases.
No, with clonidine mainly. I have
Clonidine, no,
seen
don't use
And we
clonidine.
do not
Clonidine,
prolonged
no, 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 no.
hypertension
Obstetric
postoperatively.
cases.
we
We are
Yes.
haven't
not
used
using
this in
clonidine.
obstetric patients.
I wanted to ask Manisha madam, suppose now there's a hypotension and I'm using mephenteramine. I have already given 6 or 12 milligram of mephenteramine and still the BP is not coming up. The obstetrician is taking time for delivery. And now I want to add phenylephrine. Does the dose decrease after we have already given mephenteramine? Or I can give still a bolus of 100 microgram? Does it
You
cause
can
any
give,
arrhythmia?
no, but then you have to assess whether she is hypovolemic, whether you
Yeah.
need to give more fluids. Because if
There is no drug interaction you can give.
you can give, but then
So
she may, I
if
think,
if she's having a
yeah,
BP of say 90 millimeters of mercury, then there is no harm in giving her 100 mics ka bolus.
After
and what
mephenteramine, the dose does
Yes,
not reduce.
because
does not,
mephentermin is tachyphylaxis. That is promoted tachyphylaxis, so it's not going to have any effect. You can easily go ahead. But what you can is you can titrate it and give it 50 and then give another 55.
Exactly. I
So
would
there is no
titrate
need
and
to,
give. I
yeah,
would not
titrate it.
give 100
Yeah,
stat.
so there is no need to give 100 stat. Yeah, exactly.
Yeah.
Just give 50 mics
but
and
then
then the next cycle you will come
what
to
I
know.
feel is that means she really has hypovolemia as well,
No,
because
she's
I
just
have
giving you
seen
one scenario. Yeah, she's not
yeah,
really talking about that. But the thing is that also you get to know the effect of phenylephrine from the heart rate. So when 50 mics you administer and the heart rate, starts coming down, you're sure that the BP is also picked up now.
See,
And then
it's under,
look for,
yeah,
huh,
it's under cover of phenylephrine. You have to give fluids in that case.
yeah. So then you
You
look for
cannot wait
causes.
for the,
Look for causes.
yeah.
What has
So you
caused?
give phenylephrine and then you start giving fluids under cover of that,
Be-
then the BP
because
will come up.
lower BP are sure to cause maternal nausea and vomiting,
Yes,
and
yes.
that is very distressing. So once she
and
retches and she
we
vomits,
want
then
to,
surgeon also starts looking at your face because the whole abdomen goes haywire. So it's
yes,
better to control that first. Control that.
and we want
I
the
think
to come to normal
Sorry,
before the
yes, Manisha ma'am.
can't hear.
I think we will stop here
we
because
want
it's
the
9.
BP should normal before measure this. Yeah,
Hello.
Just Avinash sir,
Yes.
last question. Can we take one?
Okay. Yes, yes. It's
Preemptive
9 p.m.
analgesia.
So we'll stop after this
Okay, yeah.
last question.
Any preemptive analgesia for LSCS?
no.
No, I haven't come across any study. Subha?
Preemptive analgesia means what you want to say?
So
Before the
like,
incision, if anything has to be given
No.
to stop the pain pathways.
No,
no,
no
no,
polypharmacy before child is
no,
out.
no, 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 no. Yeah,
Child,
Before
let the
exactly.
delivery
child
of
come out
That
child,
is
no
first,
it. That is even
analgesia.
more
then you can do
important.
whatever you want.
Yeah, exactly. You be minimum on drugs before baby is born. Hmm.
Okay. Thank you,
Thank
everyone.
Much. Avinash,
Hello.
Yes,
Indrani ma'am.
yes. Sital,
Yes.
give present the vote of thanks.
So after so many discussion, let me tell you, I am that survivor of that obstetric hemorrhage. So many discussion, I am the most experienced person of all the obstetrics management you have discussed today. Anyway, it's my immense pleasure and honor to propose the customary vote of thanks. My sincere gratitude towards Dr. Indrayani Hemant Kumar Madam and Dr. Kiran Kurtukoti sir for sharing their vast experience and putting their valuable inputs in the management of obstetric patient. My sincere thanks to both the faculties, Dr. Kajal Jain Madam and Dr. Manisha Shebekar Madam. They are giving very small tips and tricks the management of obstetric patient. For I think it is not physiological obstetric, it is always pathological so many times. Now, my special thanks to the Society of Anesthesiologists, Kolhapur, the president, Dr. Aarti Jadhav, and the secretary, Dr. Praveen Chavan, for providing the MMC hours to the today's webinar. And sincere thanks to MMC observers, that is Shichir Kumar sir, Pawar sir from Kolhapur. He is a MMC observer today. And thanks to all office bearer, past office bearer, and all president and secretaries of city branches. Even so many obstetricians have attended today's webinar. Thanks to my college IGMC people for attending the gynecology department. Thank you very much. Thank you very much, ma'am.